Welcome back. On this module, on this session, we are going to discuss malaria. And malaria is caused by Plasmodium. Vivax and Falciparum, these are the two types of malaria in which fever happens every third day. And because the fever comes every third day, we call it tertian malaria. In ovale and malariae, the fever comes every fourth day. And that's why it's called quartet malaria. And it depends upon what's the particular stage in which the RBC stage, the organisms are multiplying and there is rupture. We'll discuss the life cycle, then it's going to be more clear. So Vivax and Falciparum, fever every third day, that's tertian. And ovale and malariae, fever every fourth day, that's quartet malaria. Mosquito, that's the female Anopheles mosquito, is the definitive host and the man is the intermediate host in malaria. The word was derived from the word mal area. Mal is bad and area for air. So in those days it was called as bad air, that's malaria. Falciparum is the most dangerous type of malaria. It's an acute fulminating disease and it could be fatal. Vivax is comparatively mild type of malaria. Malaria is seen mostly in the tropical regions and Plasmodium ovale is a rare type of malaria. Let's go and discuss the life cycle of malarial parasite in the man. Concentrate on the slide. The mosquito bites the human being and liberates sporozoites in the human blood. These sporozoites from the human blood go to the liver and develop in liver. Then again they come and infect the red blood cells, the RBCs. And then the RBCs rupture and liberate thousands of merozoites in the blood. And this is the particular stage when the RBC ruptures and liberates merozoites in blood. This coincides with the clinical attack or what you call as the fever in malaria. Just few minutes ago I said that we need to understand the life cycle, then we would understand about the tertian and quartan. So when the fever is happening every third day, it means that the life cycle is such that the RBCs are rupturing and liberating merozoites in the blood every third day. So the fever is going to coincide with the rupture of RBCs and the merozoites coming into the blood. These merozoites which have been coming in the blood, they start developing into gametocytes. And the gametocytes are going to be acting for the transmission of the disease further. So merozoites present in the blood, they further develop into the gametocytes, and when the mosquito bites, the gametocyte comes in the oral cavity of the mosquito. This is how the life cycle continues. Some merozoites, however, persist in liver, and these merozoites later sometime can multiply and they will be responsible for relapse. The secondary exoerythrocytic schizogony is this particular stage of merozoites persisting in the liver, and these substances, as if they are sleeping in the liver, they are in the dormant stage and later they are going to multiply. So they are also called as hypnozoites. This particular secondary exoerythrocytic schizogony is absent in Falciparum malaria. Now, since there are no dormant organism sleeping in the liver, that's the hypnozoites, in Falciparum malaria, there's not going to be any relapse in Falciparum malaria. So no exoerythrocytic schizogony, no relapse. That's characteristic of Falciparum. However, in other types of malaria, there is an exoerythrocytic stage, and this is why all the other three types, they are associated with relapse in malaria. Next we move on to the life cycle in mosquito. When the mosquito bites, it gets the gametocytes from human blood. We had come until this stage while discussing the life cycle in man. The mosquito gets gametocytes from the human blood, and these gametocytes start developing in the mosquito gut, and those who were gametocytes, now they start becoming the gametes. So they start the differentiation. That's a sexual differentiation. So life cycle in mosquito begins with the entry of gametocytes from human blood, develop in the mosquito gut into male and female gametes, and the fertilization takes place. Now, because this particular sexual reproduction is happening in the mosquito, that's why we call mosquito as the definitive host and the man is the intermediate host. Coming back to the cycle, the gametocytes differentiate into male and female gametes. The male and female gametes come together and fertilize, and there is formation of zygote. The zygote develops further into ookinete. The ookinete develops into oocyst, and this oocyst slowly ascends up in the gastrointestinal tract in a reverse manner, in the reverse direction, and the oocytes come to the oral cavity of the mosquito. And then, if the oocyte ruptures, it releases sporozoites into the oral cavity. The mosquito is going to bite a human being, and this is how the human being is going to get infected with the sporozoites. So this is how the life cycle in the mosquito is completed, and the mosquito transmits the disease to the man. We start with the discussion of the antimalarial drugs, and let's try to understand the drugs on the basis of which stage the drug is going to act. Let's have a look at the slide. The first row is telling you about sporozoites in blood. I hope you remember the life cycle. When the mosquito bites a human being, there are sporozoites coming into the blood. If you could kill these sporozoites, probably you are going to prevent malaria. You are going to prevent the true cause of malaria. And this is why this is called true causal prophylaxis. If you look at the right hand side column, we don't have a drug. We don't have a drug which could prevent or which could kill the sporozoites as soon as they came inside the blood. Look at the slide. We are going to the next row. Thus, the sporozoites are going to the liver. This is the primary schizogony happening in the liver, and the sporozoites are going to multiply in the liver. If you could stop them here, or if you could kill them here, you are still going to prevent the attack of malaria, and you can say that this is the cause, because in the liver they are multiplying, they are developing. This is the cause for the clinical attack. So if you could do this, this is called causal prophylaxis. And there are only few drugs who can do this. And look at the drug written on the right hand side in capitals. That's primaquine. Primaquine is a very important drug which can inhibit the malarial parasite in the liver when it is present there as a primary stage. So it's a causal prophylactic. Along with primaquine, we have proguanil, and we also have tetracyclines. These can do this action. But the important one is primaquine. Look at the slide. Now we move on to the next stage, and the third row is describing about the RBC stage. And in the RBCs, you have those merozoites which are going to be liberated, and this is going to produce the clinical attack. So, if you are going to act on this stage, you are going to prevent the fever. It means you are going to suppress the fever, or you are going to suppress the clinical attack in malaria. So if a drug is able to act on the RBC stage, it's called as a suppressive, or it's also called a blood schizonticide. And if you see on the right hand side, there's a huge number of drugs on this particular box. So it means that most of the antimalarial agents, they act on the RBC stage. Let's have a look what are these agents. Number one is chloroquine, then quinine, mefloquine, quinidine, and proguanil. I have put all of them together. It will be easy to remember the names. Chloroquine, quinine, mefloquine, quinidine, and proguanil. On the second line, I am writing the drugs which are little different, and that's sulfadoxine, pyrimethamine, and tetracyclines. I am writing them in a different fashion because these drugs are useful in resistant malaria. Sulfadoxine, pyrimethamine, and tetracyclines. After this, the third line is also useful in resistant and severe malaria, and these are artesunate, artemether, halofantrine and lumefantrine. So all these drugs are able to inhibit the RBC stage and they could act as suppressives. We go to the next stage. What happens in the next stage is the development of gametocytes. So if the drug is able to inhibit this particular stage, it's called gametocytocidal. Please don't call gametocidal because the gamete is not yet formed. The gamete is going to be formed in the mosquitoes, and in the human beings we only have gametocytes. The cells capable of getting developed into the gametes are called as gametocytes. So in the human beings we have gametocytes. If a drug is able to inhibit this stage, it's called gametocytocidal. What does this mean? If you are going to kill the gametocytes, what's going to happen is this particular disease, these particular gametocytes are not going to go back to the mosquito. And if they are not going, they will not develop into the gametes and there will be no sexual multiplication of the organism, and this is how the mosquitoes will not be able to transmit malaria further. So in a way, these drugs are important gametocytocidal agents. Have a look at the list: chloroquine, quinine and mefloquine, especially useful as gametocytocidal for vivax malaria. In addition, you have artesunate and artemether. They also have this action. And again, the last name written here is primaquine becomes extremely important. I would like to remind you, primaquine was active against the primary liver stage. Now primaquine is also a gametocytocidal. We go to the last box now. I hope you remember the life cycle. The malarial parasite has developed in the liver. It came to the RBCs. There is a multiplication. There is a clinical attack. After this, gametocytes are formed and are going to the mosquito. But in between this whole process, what's happening is some of the merozoites are going back to the liver and developing there and remaining dormant there, what we call as hypnozoites. These are the persistent forms. So this is called secondary exoerythrocytic schizogony. Secondary because this is the second time they are coming to the liver. Exoerythrocytic, exo is outside, the erythrocytes, that's red blood cells, means in the tissues. So this is the secondary exoerythrocytic schizogony happening in the liver, that's hypnozoites. And if you remember the life cycle we stated, this particular stage is absent in falciparum malaria. What's the importance, relevance of this stage? These particular organisms are going to remain dormant and later they are going to multiply. So they are going to be responsible for relapse. In falciparum, you don't have this stage. So there is no relapse in falciparum malaria. Whereas the rest of the three types of malaria, you have the secondary exoerythrocytic schizogony. So these three types of malaria, that's ovale, malari and vivax, will be associated with a relapse. So let's come back to this box and understand, if you are going to kill these organisms, kill these forms, that's the hypnozoites or the secondary exoerythrocytic schizogony, then you are going to prevent the relapse. And we're talking especially about vivax, malari and ovale. And look at the right side, look at the right column. Who is there in this box? Only and only primaquine. Only primaquine can inhibit the secondary exoerythrocytic schizogony. So to summarize this whole table, most of the drugs, they act on the RBC stage. The traditional drugs like chloroquine, mefloquine, they act. There are drugs which are useful in resistant malaria like sulfadoxine, pyrimethamine and tetracyclines. Plus those who are used in severe malaria and resistant malaria like artesunate, artemether, halofantrine, lumefantrine, etc. As far as the gametocytes are concerned, yes, chloroquine, quinine, mefloquine are useful. In addition, artesunate, artemether is useful. And when you think of that one drug which is acting on three different stages. That's primaquine. It inhibits the primary exoerythrocytic stage in the liver. It inhibits the secondary exoerythrocytic stage in the liver, and it also inhibits the gametocytes. So when it inhibits gametocytes, it's going to prevent the further transmission of the disease. When it prevents the primary stage in the liver, that's causal prophylaxis. You could use it for prophylaxis or prevention of malaria. And when it's inhibiting the secondary exoerythrocytic schizogony, it's going to prevent the relapse. Primaquine becomes a useful drug from these three aspects. And lastly, don't forget, primaquine is not there in this red box. Primaquine is not able to suppress the RBC stage. It's not a suppressive. So if you want to terminate the clinical attack of malaria, don't think of primaquine. Primaquine will be useful for prophylaxis, will be useful to prevent the relapse, and will be useful to prevent the transmission by killing the gametocytes. So I think you concentrate and you wait on this table for some time and try to say the things which I said, so that you will have a perfect idea which drug is acting on which stage. We move on to the next slide and try to understand what is a radical cure. A radical, the word itself is giving you a radical feeling that's going to do everything. That's called radical cure. What is a radical cure? See, you suppress the RBC stage so that you terminate the clinical attack 1, and you're also able to suppress the persisting forms in the liver. Then we call it radical cure. So you're killing the organisms in the RBC stage, plus you are killing the persistent forms in the liver. This will be called as radical cure. In falciparum, as we said, there are no persisting forms in the liver. So even if you just suppress the RBC stage, it becomes a radical cure for falciparum malaria. Whereas for the other three types of malaria, you need to inhibit both the stages. In falciparum, there is no relapse, there is no secondary exoerythrocytic schizogony. So just kill the RBC stage, it means radical cure. And in other types of malaria, you need to suppress both the stages, the RBC stage and the persistent organisms in the liver. Chloroquine is a drug which can be radical curative for falciparum malaria, because chloroquine acts on the RBC stage and there is no secondary exoerythrocytic schizogony. So obviously a drug which is just suppressive becomes a radical curative in falciparum malaria. Out of the antimalarials, we can say what are the fastest acting agents. The fastest acting agents are quinine and quinidine, artesunate and artemether. Quinine, quinidine, artesunate and artemether. The drugs which are not so much fast acting, but still you can consider them as fast acting, are chloroquine, mefloquine, halofantrine, lumefantrine, and a reserve drug, that's atovaquone. The drugs which are in general slow acting are sulfadoxine pyrimethamine, tetracyclines, and proguanil. So if you think of producing an acute effect of the drugs, think of quinine, quinidine, and the newer drugs artesunate and artemether. The drugs which are traditionally used in malaria, like chloroquine, mefloquine, etc., they are fairly fast acting. And sulfadoxine pyrimethamine and tetracyclines are comparatively slower acting agents. We go to the next slide to discuss chloroquine phosphate or chloroquine in details. Chloroquine is useful for acute attack of malaria, and the chloroquine base is 150 milligrams. The tablet strength might be written as 250 milligrams because of the tablet of 250 milligrams, but the chloroquine base is 150 milligrams. To avoid the confusion, I am clarifying this so that you can just think of how many tablets to be given instead of calculating the dose, as 4 tablets would become 600 milligrams or it would become 1 gram. So chloroquine base is 150 milligram in a 250 milligram tablet. Give 4 tablets immediately, stat is immediately, 2 tablets after 6 hours, and then 2 tablets every day for next 2 days. So you get a pack of 10 tablets, 4 tablets just now immediately, 2 tablets after 6 hours, 4 plus 2 has become 6. Tomorrow 2 tablets and day after tomorrow 2 tablets. So 6 plus 2, 8 plus 2, 10. So that's a course of 10 tablets. As we already said, it will be useful against these sensitive strains, of course. So that's the management of acute attack of malaria with chloroquine. Coming to its uses, we put the first use as acute attack of malaria, the second use as extraintestinal amoebiasis, that's liver abscess, because chloroquine is a tissue amebicide and it inhibits the amoeba only and only in the liver. The third use is it is an anti-inflammatory drug and it is a disease-modifying anti-rheumatic drug. So you can use it for lepra reactions, you can use it for lupus erythematosus, rheumatoid arthritis and infectious mononucleosis. It's useful against Chinese liver fluke, fish tapeworm and also giardiasis. So these are the uses of chloroquine. On this session, we discussed about the strategy in malaria and chloroquine.